Welcome back to Uncovering Daily in Love with Snazzy Surgeon. Let's jump into a deep dive on common breast lesions that we, as surgeons, encounter all the time, specifically cysts and galactocoles.
Yeah, these are things we see pretty routinely in practice. But despite their common nature, I think it's worth revisiting their nuances because they can really impact our management approach.
Absolutely. Let's start with breast cysts, which are incredibly prevalent, especially in women between 35 and 55.
Yeah, that age group definitely keeps us busy.
For sure. Patients often come in with a new breast lump, and even if it's painless, there's always that anxiety about malignancy. It's remarkable how suddenly these cysts can appear, too.
Oh, absolutely. That sudden onset is a real hallmark. And when we think about it from a pathophysiological perspective, it makes sense, right? We're talking about the anti-eye spectrum, so lobular involution plays a role, often with increased secretion in the ducts and potential obstruction. Then, of course, you have the added influence of hormonal fluctuations. Things like hyperoestrogenemia and hormone replacement therapy can definitely contribute.
So picture this. A patient presents with this new lump. What's our first move to figure out what we're dealing with?
Well, ultrasound is our go-to, no question. It's invaluable, not only for confirming that it's a cyst, but also for guiding aspiration if needed.
Makes sense. And how does the BI RAIDS classification come into play at this point?
BI RAIDS helps us stratify our approach. So if we see a classic smooth-walled cyst on ultrasound, no solid components whatsoever, that's a clear BI raise 2. And typically, observation is all that's needed. Being really comfortable with those sonographic features of a BI raises 2 cyst, I think that's key. It helps us avoid unnecessary interventions and really reassures the patient.
That's so important, calming that initial fear. Now, what about those cysts that aren't so textbook, the ones that throw us a curveball?
Right. When we see a solid component within that cyst wall on ultrasound, that's when we're talking about a complex cyst. And in that situation, a core biopsy is absolutely mandatory to rule out something more sinister like cystadenocarcinoma.
Ah, I see. So those complex cysts raise the stakes a bit.
Exactly. And, we also encounter those complicated cysts. These are the ones with mobile intracystic debris, which can look like anything from inspissated fluid to actual cellular material. Those warrant a close look as well.
So at what point do we shift gears from simply diagnosing these cysts to actually treating them?
Well, if a cyst is causing symptoms, things like pain or inflammation, then aspiration is definitely indicated. We also consider aspiration for those large solitary collections that are just taking up space. Now, after aspiration, if the cyst resolves completely and the fluid we get out isn't blood-stained, we're usually good to go. No further action needed. Interestingly, cytology on simple cyst fluid is pretty much useless. Doesn't really tell us much.
But what if we aspirate and the cyst doesn't completely disappear? Or what if that fluid we pull out is hemorrhagic?
That's a red flag. A residual lump after aspiration or any blood in that aspirate, that means we need to go further. A core biopsy, or maybe even an excision, is necessary to get a definitive histological diagnosis. And of course, if we're dealing with an infected, complicated cyst, a round of antibiotics might be in order.
Good points. Now let's switch gears a little and talk about galactocoles. They're a bit less common and usually seen in a particular group of patients, right?
Yeah, you got it. We see them in lactating women, either during breastfeeding or shortly after. They typically show up as a solitary lump right under the areola.
And I imagine the management of galactocoles is quite different from what we've been talking about with cysts.
Oh, absolutely. In most cases, a single aspiration is all it takes to resolve a galactocele completely. If it comes back, we can try aspirating again.
So a more conservative approach generally works well.
Usually, yeah.
Yeah.
But in those persistent cases where aspiration alone doesn't cut it, sometimes passing a small nylon strand, like a 20, through the duct can actually help clear a blockage. We can break up any little adhesions or debris that's causing trouble.
Interesting. So any potential long-term complications with galactocoles we should be aware of?
In rare cases, a galactocele might not resolve fully because of inspissated material or even calcification. But even then, surgical excision is rarely necessary. It's really the last resort.
And for those breastfeeding moms who develop a galactocele, what's the key message we want to convey?
Reassurance is key. We want to let them know that it's a benign condition and that it shouldn't stop them from breastfeeding. Continuing to nurse is absolutely fine and usually helps things along.
All right, so just to recap for our colleagues listening, We have the simple cysts, most commonly seen in women between 35 and 55, often resolving beautifully with aspiration. Then we have those complex and complicated cysts, which require a bit more caution and usually need a biopsy to rule out anything serious. And finally, we have our galactoceles, typically found in breastfeeding women right under the areola, and those usually respond well to a simple aspiration.
You nailed it. And I think the big takeaway here is that ultrasound is our best friend in all of these scenarios. It's crucial for both diagnosis and guiding our management decisions.
Could not agree more. Well, I think we've covered a lot of ground today. Thank you so much for joining us.
My pleasure.
And to all our listeners, thank you for tuning in to Uncovering Bailey in Love with Snazzy Surgeon. We'll catch you in the next episode.